In the bullous diseases disorder, we're going to compare pemphigus with pemphigoid, and that's the major thing you're going to take away from this lecture. And then we'll finish up with some of the diseases that are commonly tested against these diseases and some of the pitfalls you might encounter. So let's start off first by building what the cell layer actually looks like. So normally, you've got epithelial cells that are in a layer. And they are connected to each other by desmosomes. And then this bottom layer is attached to the basement membrane by hemidesmosomes. So that if you damaged hemidesmosomes, you would lose the connection of the cells to the basement membrane. If instead you lost desmosomes, the things between cells, the cells would fall apart from each other. So let's see what this looks like. If you lost desmosomes, the hemidesmosomes would still be intact, and the cells at the basement membrane would stay attached. But because you lost the desmosomes, the things that connect all the other cells together, you're going to see all these cells floating around in space. Because they're not connected to each other, if a blister formed, there's lots of gaps. And so that blister would be thin-walled and easily friable. And because these are caused by autoimmune diseases, if you did histochemistry staining, immunofluorescence, what you'd see is immunofluorescence all over the slide because it's going to be at the site of every cell. If instead you lost hemidesmosomes, the cells themselves would still be connected to each other because the desmosomes are still intact. But the whole layer wouldn't be attached to the basement membrane anymore. This blister is going to have a thick wall and therefore will not rupture easily. And if you did some staining, what you'd see is stain only at the basement membrane. And that's a lot of pathology, but it makes this very easy if you understand the difference up front. This is pemphigus, this is pemphigoid. Let's see how we use it. Pemphigus is the bad one. Pemphigus vulgaris. It's vulgar, so it's the bad one. Here you've got antibodies against desmosomes, specifically desmoglein. And as we just talked about, if you have lost your desmosomes, the cell layer will not be intact. And so, being thin-walled and floppy, you'll have a positive Nikolsky sign. The blister ruptures with just gentle traction. And what you want to remember about this is that it does involve the oral mucosa. If ever you see somebody with a blistering disease, shine a light in their mouth, see if you see the blisters there. Because pemphigus, the bad one, is a life-threatening condition. You diagnose it because you caught the oral lesion, you can save someone's life. This usually happens in people who are a little bit younger, 30s to 50s. The diagnosis is going to be made on a biopsy. The biopsy is going to show you thin-walled blister with cells all over the place. And if you did immunofluorescence, you'd see it throughout the whole slide. The treatment for pemphigus is steroids. High dose, all at once, and then you can transition to steroid-sparing agents like mycophenolate mofetil or rituximab. Pemphigus, life-threatening condition, positive Nikolsky sign, positive oral lesions, biopsy gives them steroids. Now, pemphigoid is like pemphigus, but because it's pemphigoid, it's not as bad. The pathology here, the antibody is against hemidesmosomes. The patient here is going to be a little bit older, 60s to 80s, and it's the other thing. Thick wall, no Nikolsky sign. It's a strong bulla, and it does not involve the oral mucosa. You can diagnose it the same way, you get a biopsy. But now in that biopsy, you see an intact epithelium and an immunohistochemistry. What you'll see is the basement membrane light up, but not the rest of the slide. Treatment here is with steroids. Systemic if it's widespread, or topical if it's local. Pemphigoid, older people, 60s to 80s, non-life-threatening, no Nikolsky sign, no oral mucosa. Biopsy it, give them steroids. And then tested against these diseases are going to be two other conditions. The first is dermatitis herpetiformis. And this is a great test point because it is a cutaneous manifestation of a gastrointestinal disease. It is essentially celiac sprue. In this case, IgA deposition occurs in the dermis. So if you can imagine this being the basement membrane, it's going to have a layer of epithelium, which we just got through talking about, and then in the dermis, in the papilla of the dermis, IgA gets deposited. As you deposit more IgA there, these things begin to stretch out and grow. So what you get is a raised lesion. The basement membrane is still there, the epithelial layer is still there, so you get a raised lesion that looks like a bulla, but it's not. So in this case, you've got anti-transglutaminase antibodies, IgA, depositing in the ruga of the dermis, and this presents as a vesicular lesion. It looks like herpes, usually on the extensor surfaces or the buttocks. You see a picture of someone's butt and it looks like herpes, it's probably going to be this. They're probably not going to give you the GI history. So look for celiac symptoms, but they're probably not going to give that to you. To make the diagnosis, you could get a biopsy. And the biopsy will show you a neutrophilic abscess. If you see the word neutrophilic abscess, you're done. But this is actually the wrong thing to do. You don't want to get a biopsy of the skin lesion. You say, that's dermatitis herpetiformis, this is celiac disease. That is to say, everybody with dermatitis herpetiformis has celiac, but not everyone with celiac gets this rash. What you want to do instead is get the antibodies, anti-transglutaminase and anti-endomyocele. It's the first step for diagnosing celiac disease, because what you want to do is not diagnose dermatitis herpetiformis, but diagnose the underlying condition. And the way you definitively do that is do an EGD and get a biopsy of the small bowel. The treatment is with dapsone. If you give dapsone to dermatitis herpetiformis, the lesions go away. But you're not treating the disease, so this is probably going to be the wrong answer. What you want to do instead is avoid gluten. And lastly, lowest yield on the list, Porphyria cutanea tarda. There's a lot of enzymes you have to remember in heme synthesis. What you care about now is uroporphyrinogen. The patient is going to present with blisters on sun-exposed areas. This is a genetic disease in which you should look for is lots of hair, hypertrichosis, and easy blistering on sun-exposed areas, usually the dorsum of the hand That's porphyria cutanea tarda. And the test likes this one so much because see a rash or a blister, look at the urine. The diagnosis is made with a wood lamp, which turns coral red. The treatment, unfortunately, is to stay out of the sun because a genetic disorder can't treat it. But the way they'll get you in the test is with the associated diseases that brings this out. So people might have this genetic disease but not display it until they're hit with another insult. So look for things like hep C, hemochromatosis, and recent initiation of oral contraceptives. Okay, let's hit it one time through, rapid fire. Pemphigus, positive Nikolsky sign, positive oral mucosa, life-threatening illness, steroids. When you get a biopsy, you're going to see the basement membrane intact and immunofluorescence everywhere. Versus pemphigoid, which happens in a little older people, rigid bulla, negative Nikolsky, negative mucosa. The biopsy will show an intact epithelium and the stain will show up only at the basement membrane. Also give it steroids. Dermatitis herpetiformis, celiac disease. If you see a vesicular rash on an extensor surface, diagnose celiac disease, treat celiac disease, and keep Dapsone in your back pocket for symptomatic relief. And porphyria cutanea tarda, if you see hairy and blisters on the back of someone's hands that are sun exposed, shine a light on their urine. That is Bullous diseases.